Good afternoon, everyone, and thank you for joining us again in our series of webinars for PHNs. And today we will be working on the topic of alcohol and other drug use within LGBTI communities. My name is Rebecca Reynolds, and I'm the Executive Director of the National LGBTI Health Alliance, and we coordinate a series of projects and have a lot of work happening in a number of different areas. And this series is meant to give you some insight, information and support into working in these areas and referral into organisations that can help you further with your work. Before I hand over to our presenter for today, I'd like to begin by acknowledging the traditional custodians of the lands on which we meet across Australia and pay my respects to their elders past and present. And as a matter of practice at the Alliance, we also honour our LGBT and I elders for their resilience and commitment to equality, and without whose efforts we wouldn't be having the opportunities that we do today. So thank you for joining us, and without further ado, I will hand over to our presenter today to talk about alcohol and other drug use within LGBTI communities, Tanya Thompson.
Thanks, Beck. Hi, everybody. Thank you for joining us today. As Beck said, my name's Tanya Thompson. I'm the National Capacity Building Manager for Q-Life here at the Alliance. But in my past couple of roles, I've worked in the drug and alcohol field, primarily with LGBTI people. So that involved doing direct service provision work, working with users in pharmacotherapy clinics and staff in pharmacotherapy clinics, and prior to that, working in community development around harm reduction procedures for people who use drugs and alcohol. You may or may not be familiar with this program, but there's an option for you to type questions into the program. Please feel free to do that at any time during my presentation, and I will stop and answer them. If I don't get to it straight away, I've got a lovely sidekick who's going to keep an eye on things for me and make sure that I don't forget anybody. If I do happen to miss a question, we will email a response to you after the webinar's finished. I'm going to be really careful about acronyms. I know within LGBTI field and within drug and alcohol field, there are a lot of acronyms. So if I do say something, say something that you don't understand or you don't know the meaning of, please feel free to type me a message and let me know. Okay, so briefly, the things that we're going to touch on today in this webinar is the kind of language that we use when we're talking about LGBTI people and drugs and alcohol, the research that's currently available and also the lack of research that's available in this field, the differences between how LGBTI people use drugs and the broader population use drugs, and what these differences mean when you're developing treatment programs or education, harm reduction programs, things like that. Okay, so yeah, as I said, please feel free to ask questions at any time. So language is really important. As we know, language is constantly evolving. This is both in the LGBTI field and in the AOD field, alcohol and other drugs field. So I just wanted to quickly just touch on that for you. During this presentation, I will say LGBTI a lot, probably a little less on the I, and I'll explain that as we get there. So it's lesbian, gay, bisexual, transgender, and intersex people. If I say AOD, that's obviously alcohol and other drugs. And other than that, I'll try to avoid the acronyms, as I said. Something that's really important to remember when you're working with people in the drug and alcohol field is that it's a really emotive subject. It's a really emotive topic. People who have been using drugs or alcohol have probably faced stigmatisation in their lives, particularly LGBTI people. So you're dealing with people, really marginalised communities. So it's super important to remember how stigmatising language can be. There's been a really obvious shift in drug and alcohol language over the last few years, and that's been away from terms like dirty and clean. So you used to say, it used to be said that you were getting clean injecting equipment rather than sterile injecting equipment, or that somebody was clean because they weren't using drugs or alcohol anymore. So this is, I suppose, a really good demonstration of how language has changed, and we've stepped away from that stigmatising language. Something else that's really important to think about in terms of language and how you talk about drug and alcohol is that a lot of people who work in alcohol and other drugs field have lived experience. They're drawn into this kind of work because they've had personal experience or they've had loved ones with personal experiences. So again, it's really important to remember that you don't know the life experience that your colleague has had. You don't know the experiences of the people sitting in the room with you. And this kind of stigma is something that's really, really hard to let go of. So just remembering to always be careful the way that you talk about alcohol and other drug use, because you might be talking about somebody, you might be sitting next to somebody who's had lived experience of this. So that's just something that I like to, remind people to think about particularly when you're talking with clients, if you're talking with family members or colleagues. Just water break. Another thing that I think it's really important to remember that we often forget, I think particularly when we're working in a sector, is that not all drug and alcohol use is problematic. That you may get clients who, you may be working with clients or meeting with people in the community who may not actually see their own drug and alcohol use as problematic, or they may not actually be want to achieve abstinence. So it's really important to remember this, that you need to put the client's position first when talking about drug and alcohol, when you're talking about end goals, finding out what people are actually after, rather than just assuming that just because somebody uses drugs that it is having a negative impact on their lifestyle, or that assuming that they would want to reach abstinence. They might just want to control their use or minimize their use, or just get information and education about their use. So that's, again, just about checking in with clients and understanding, listening to the language they're using and the goals that they're trying to achieve. There's different types of use, and I'll be talking about different types of use throughout this presentation. So I've just got a question. Let me just double check what it is. I know that you said you'd stick away from acronyms, but I'd love some reinforcement over the acronym, the Q, in official documentation and wanting to be inclusive of all members of the communities. Should I use questioning or queer? Wow, that's a great question, straight up. We've got some resources that we'll send to you, an inclusive language guide and some information on language. But that's a really good question. It's something that we stumbled across a lot when we started QLife. So with reclaiming of language, queer is a word that's obviously been reclaimed by a lot of communities, particularly younger LGBTI people. What we found when we were focus testing the branding for QLife was that a lot of people, well, not a lot of people, but there was a percentage of the population, primarily older LGBTI people, who had had the word queer used in a derogatory way. They'd had that thrown at them as an insult, and so they were uncomfortable with the word. So what you'll notice in the QLife branding is that we never actually, we don't often use the word queer as a whole word, and we don't ask our volunteers to identify as queer or use the word at all if they're uncomfortable with it. It is a word that a lot of people really love and have reclaimed and feel that it encompasses everybody. So it's really down to comfort factor. So yeah, as I said, we can send you out, we'll definitely send out a language guide and it'll be available on the website, but that is a bit of a tricky one, and it's about respecting the comfort level of the people you're talking to. I know that's kind of clear as mud, but I do hope that it helped a little bit. So the different types of drug use that I'll be talking about in this presentation is recreational drug use. So this is when people use drugs occasionally, but there's not a serious impact on their lives. So they might go to a Mardi Gras party and take an ecstasy pill, or, they might have a line of cocaine on their birthday, or they might go out dancing once a month and take some drugs, but they're still financially okay. It's not impacting on their work life. It's not impacting on their relationships. It's not impacting negatively on their health. So it's a comfortable level of drug use, I suppose. And this will be different for every individual. Every individual will respond differently to all kinds of drugs and all level of use. Problematic drug use is when people use drugs and they start to impact on their lifestyle negatively. So that could be that you're spending too much money. It could be that you're finding that you can't go to work on Mondays or Tuesdays. It might be impacting your relationships, things like that. And as I said, that'll be really different for different people. It's really individual how much use is too much and how much is recreational. Dependent use is when somebody has a physical or psychological addiction. They have to use a drug. physically go into withdrawal if they're not using it, or they psychologically have discomfort if they're not using it. You hear about this primarily with opiates, people that end up using pharmacotherapy as a way to maintain opiate use. So lots of drugs are addictive, but the one that you hear the most reference to for dependent use would definitely be opiates. As I mentioned at the beginning, I was going to talk to you about research and also the lack of research. So there's very little drug and alcohol research out there that includes questions around gender and sexuality. So a lot of the information that we have on this within the LGBTI community is anecdotal evidence. It's really important that we still continue to maintain programs and projects and develop treatment options for LGBTI people. So if we're unable to do that based on research, we do it through anecdotal evidence. We do go out and talk to community members. We do keep track of medical calls at events. We talk to experts in the community. We talk to drug and alcohol service providers. We talk to needle and syringe providers. We talk to community groups, things like that. So there is a lot of anecdotal evidence out there, but there is some research. So I'm going to tell you a little bit about the research that is out there. Now, when I start to talk about data and numbers and things a bit further into this presentation, that has all come from the research I'm about to tell you about, I'm about to list for you. And I can give you a reference list at the end. I haven't included one on my slides, but we can pop one up on the website for you. Also, feel free to contact us if you have any questions about any of the research. These are some comparison studies. So these are studies that include questions on gender or sexuality, and these studies survey both the broader population and the LGBTI population together, so we can get a direct comparison. So the National Drug Household Survey, it's a bit of a mouthful, that one, the NDSHS. This is a survey that happens every 3 years. Now, this study directly impacts our national drug strategy in Australia. It's a random survey. It's done over the telephone, and it's anybody over the age of 14 years old can answer the survey. In 2007, before 2007, it didn't have any questions about sexuality, and it didn't have any option to say if you were transgender or intersex. In 2007, they added a question on sexuality. So I can't remember exactly, I think it's heterosexual or not heterosexual. There's still no opportunity in this study to say whether you have transgender experience, and there's still no opportunity to say whether you're an intersex person. Actually, I'm just going to preface this and say none of these studies have the option to say whether you're an intersex person. So from here on in, when I'm talking about LGBT people, that's not an accident. I don't feel that we're suitably placed to make comment on intersex people and their drug use, because the research out there, there just isn't enough. So this is a really big hole. If you feel like doing some great drug and alcohol research, this is definitely a gap where we need some more research done. So the NDSHS added a sexuality question in 2007, and it's been asked in every iteration of the survey since then. The Ecstasy and Related Drugs Reporting System, the EDRS. This is a brilliant survey. I've worked on this one myself. This is incredible. It does include questions about gender, and it does include questions about sexuality. It's a bit of a three-pronged approach, this survey. So people go out and they interview drug users. So as by the title, you can tell this is people who use drug, what we call party drugs, I suppose. So ecstasy, cocaine, methamphetamine. Often these interviews are done at big cultural events where people will be using drugs, things like Big Day Out and other festivals like that. So as well as people going out and interviewing drug users, they also interview key experts, so drug and alcohol workers, police, ambulance officers, first responders, things like that. And they also work really closely with the police as well on seizures, charges, things like that. So this, apart from just numbers of people using drugs, the EDRS looks at the price of drugs, the purity of drugs, and how regular people are using them. So this identifies changes in trends across drug and alcohol across Australia. So it might tell us that there's been a lot of seizures of methamphetamine, and we can see that there's a lot of methamphetamine use happening and it's on the increase. What this does is it allows us to start to formulate systems and campaigns and education materials to be effective, to understand what kinds of drugs people are using and how we can support them in these situations. This has a question in there around gender and also a question around sexuality, as does the IDRS. So that's the illicit drug reporting system. They're done by the same group of researchers, but the people interviewed for the IDRS are more injecting drug users, people who would access a needle and syringe program. So that's an NSP. I might say that during the presentation. It's a needle and syringe program where people can go in and get sterile injecting equipment. It's also a great place for people to get information and knowledge on using drugs and how to use drugs safely and the kinds of drugs that are out there. Okay, so they're the main comparison studies that happen in Australia. So they talk about the broader population and they also look at LGBT people as well. Then there are a couple of LGBTI specific surveys. These two surveys do allow questions around intersex people, but as I said earlier, the sample's not really big enough and there's not enough research out there for me to feel confident in presenting data to you on this issue. So it's great that there are these LGBTI specific studies, but what we're finding is that they're very metrocentric. So the one that the top study listed here, the Sydney Women's and Sexual Health Survey, the SWASH survey, that's as it says, it's conducted in Sydney, and that's questions asked of women who are same-sex attracted in any way. So lesbians, or bisexual women, women who don't identify in any of those ways but have sex or attraction to women. And the same, or similar, is the Gay Periodic Survey, which is for Sydney men who have sex with men. The Sydney Gay Periodic Survey also has quite a heavy focus on HIV and AOD use and how they may interact or contribute to each other. So as I said, it's brilliant that these surveys are out there, but they are very Sydney-centric. So what we hear anecdotally is that there's a lot of drug use in regional areas, particularly amphetamine use, but we're not out there surveying this group. We're not catching that information, unfortunately. I'll give you a second to have a quick look at this graph. This is a bit of a snapshot that compares drug and alcohol use between the broader population and LGBTI people. So you'll see there, it looks at tobacco, any illicit drug, ecstasy, and cannabis. And it's past use in the last 12 months. So if you have a look, the red panels are heterosexual men. The yellow is gay or bisexual men. That's higher than heterosexual men. Heterosexual women is the green graph, and lesbian and bisexual women are the purple. So you'll see that the heterosexual men and women are much lower than the gay and lesbian or bisexual people. Any illicit drug use in the last 12 months, it's quite a good indication. So 17% of heterosexual men had used some kind of illicit drug in the last 12 months. 36% of gay or bisexual men had, 11% of heterosexual women, and 29% of bisexual women or lesbians. So you can see there really is a significant difference there. And these are things that we need to consider, that we can see that LGBT people are using drugs at a much higher rate. But surprisingly, most of the campaigns and most of the services out there are targeted at the broader community. They're not tailored to fit the needs of LGBTI people. What I'm going to tell you now, what we're going to look at now, is I'm going to drill down and be a bit more specific and tell you some of the differences between how the broader community and how LGBTI people use drugs. So when we're talking about these examples, it's really important, I suppose, to think of the picture all the way through. So not only is the experience, the drug using experience for the LGBTI person, but the reason that they're using drugs is quite different. for LGBTI people compared to the broader population, and then following through to their treatment experience. So we're seeing that these higher number of LGBT people are using the drugs, but the treatment providers aren't necessarily tailoring services for them. So I think it's a really important correlation to make that the higher of people seeking help we should be providing, and it's so important to be providing inclusive services, messaging that talks to LGBTI people, education for LGBTI people. So some of the key differences, the areas that are much different between the broader population and LGBTI people, probably the main one, and the one that I think I find really interesting, and I think it's really important to think about when we're developing harm reduction strategies, is about age. So lesbian and bisexual women start using drugs much younger than the broader population. So about 15 years old, 14 or 15 years old is what comes up in our research as the age of initiation into drug use for lesbians and bisexual women. So often, if you think back to your education in high school, have a look at your drug and alcohol campaigns now, they're not often aimed at people at this younger age. So there is a bit of an assumption that you don't need to start talking to people about drug use until they maybe are 15 years old or so. But these people have already initiated into use. So the time to have the conversation about safe use and to get in quickly has already passed. So we need to think about targeting messages to younger same-sex attracted women. Now, you might not necessarily know that the kids sitting in your classroom are same-sex attracted, or the young people you're working with. So maybe we need to be messaging everybody from a younger age. I know this is a very tricky and sensitive issue, but it's so important to be getting harm reduction information to people before they actually start using drugs, so they can make a choice, an educated choice. Gay and bisexual men start using, this is really interesting, they start using drugs when they're older than the broader male population or the broader population in general. But interestingly, they continue using drugs much further into their lives. So the broader population, their drug use starts to drop off in their 30s. Older gay and bisexual men continue to use drugs. So again, with that messaging, the safety messaging, the harm reduction messaging, we can't just stop sharing these messages with people because, they've turned 30, they've settled down, they've gotten more sensible, they've slowed down. It's important that we keep providing harm reduction messages for gay or bisexual men because their drug using career is much longer. We also need to think about how drug use starts to affect people physically as they get older. So it's really important to think about people's physical and emotional health as they age and they do continue to use drugs. So whereas the broader population may have stopped using drugs by the time they're in their 40s, 50s or 60s, so they're not really thinking about their health impacts or how they change as you age, that's not the case for gay and bisexual men. The level of as we discussed, is much higher. It's more than 3 times, LGBT people are more than 3 times more likely to use psychostimulant drugs than the broader population. So that's things like ecstasy, cocaine, methamphetamine. You would have heard about, the coming of the Ice Age. We have seen increased methamphetamine use across the whole community over the past 10 years, but probably, past 5 years. It's continued to go up. So that has affected the whole community. It's definitely affected the LGBT community. If you get a chance to have a look, and we can send you a link, the results of the Sydney Gay Periodic Survey have just come out. There's some really interesting data on there about methamphetamine use and gay and bisexual men. Now, LGBT people are far more likely to misuse pharmaceuticals than the broader population. So using prescription drugs, but in a manner that they're not prescribed. So they may be drugs that are prescribed to them, but they use them in an off-label manner. So you may have had an injury and be given painkillers, but you might be continue to use them not in the manner that the doctor prescribed. So this is a misuse of pharmaceuticals or using somebody else's pharmaceuticals that you don't actually have a prescription for. LGBT people are also 4 more times more likely to inject drugs than the broader population. The positive about this is that needle and syringe programs provide an excellent avenue for getting education and harm reduction advice to people. Generally, people that go to needle and syringe programs to access sterile injecting equipment are very friendly with the staff that work in there. There's often volunteers that work in there as well. So peer-to-peer is a great way to share information, particularly harm reduction information. Now, we know anecdotally that LGBT people are more likely to take on advice and information that they get from a community member. So if you're working in a needle and syringe program, or you're running or funding a needle and syringe program, a really good way to make that program inclusive would be to have information and resources that talk to the LGBT community. So as I said, the LGBT people are 4 times more likely to inject than the broader population. So think about that when you're putting your campaigns, harm reduction information, when you're seeking volunteers to work in the needle and syringe program, that it would be great to include LGBT people in there. Also, the Synergay periodic survey that I've been talking about a bit, they have some really great data talking about comparing HIV negative and HIV positive men and injecting behaviours between negative and positive men too. It's definitely worth having a look at that report. Okay, so continuing to talk about the level of drug and alcohol use, 30% of all lesbian and bisexual women use tobacco daily. Now that's compared to 13% of heterosexual women. So it's a massive difference. This is a really interesting and good way of highlighting that harm reduction campaigns that are effective in the broader community aren't necessarily effective for LGBTI people. So we know that Australia has been promoting smoking cessation for many years now. The Council's done some amazing work, and there have been many, many initiatives put in place to support people to stop smoking. So clearly this has taken really well in the broader community, with only 13% of women in the broader community using tobacco daily, but 30% of lesbian and bisexual women are. So clearly this messaging it's not hitting the mark with lesbian and bisexual women. So this is a really good example about the importance of appropriate messaging and how important it is for LGBTI people to be able to see themselves in these health promotion messages, to have materials that speak directly to our communities, because the things that are working in the mainstream are not working in this situation. Lesbian and bisexual women also report the highest use of cannabis out of anybody in the community, so higher than the broader community, higher than gay and bisexual men. And lesbian and bisexual women are also twice as likely to drink at high or risky levels. Interestingly, lesbian and bisexual women are more likely to have anxiety and depression than the broader community, or than gay or bisexual men too. So there can be a correlation between mental health and drug and alcohol use, but we'll talk about that a little bit later on. The settings for drug and alcohol use is another area where it really differs between LGBTI people and the broader community. LGBT people are far more likely to use drugs and alcohol in social settings than the broader population, and they're far more likely to use drugs and alcohol in sexual settings than the broader population. So this is another reason why we need targeted health promotion campaigns for LGBTI people. And so you as a service provider, why money, or not necessarily money, but time and thought needs to be put into creating campaigns that talk to LGBTI people in the settings where they use drugs. So for example, if we're talking about drug use in sexual settings, we need to think about the other risks that may occur if people are using drugs in a sexual setting. So we need to think about lowered inhibitions. We need to think about promoting safe sex and safe drug use at the same time. There are really easy ways that you could do this. If you're a drug and alcohol service, it's really easy to have a bowl of condoms and a bowl of lube on the counter. It's really easy to have safe sex messaging along with your drug and alcohol messaging. Over the years, there have been a few campaigns that looked at this specifically. There's a campaign quite a few years ago, the Don't Share a Bloody Thing campaign. It talked about injecting in sexual settings, and it was for gay and same-sex attracted men, gay and bisexual men. So, yeah, it's really important just to combine your harm reduction messages. And we do know that harm reduction messaging is far more effective in our communities than abstinence-based messaging. We'll talk about that a bit further on too. As I mentioned, it suggested that a disproportionate amount of LGBTI social connections happen in areas where there are drug and alcohol consumption happening. So that might be at festivals and events, it might be at gay venues, at bars, at parties and things like that. So when we think about drug use in these settings, things that we can do as a service provider to minimise harm in these settings is providing drug and alcohol messaging in venues, providing targeted campaigns in venues. So, you know, having a poster on the back of a toilet door, having information at the bar, having staff in venues that understand harm reduction and how to support people if they're having a not good time because they've used drugs or alcohol and it's become problematic. It's about providing training and support to venue staff and to security staff so they can identify people who might be using drugs or who might be in difficulty because they've been using drugs. This is something that the LGBTI community does really well. They do community support and harm reduction really, really well. And we're going to touch on that a little bit more. Another thing to think about with the high use of drugs and alcohol in social settings is, I suppose, I don't want to say peer pressure, but the feeling that LGBT people may feel that they need to engage in drug or alcohol use to fit in or to be part of the group, or also the feelings that this kind of use can be normalised because people see it when they're going out to venues all the time. So it's really important, again, I think this all comes back to education and providing information for people. So it's ensuring that people have access to drug and alcohol information and harm reduction advice before they go out, so they can think about these things. So if you're a young gay person and you're going out to a gay nightclub, maybe for the first time, maybe you've just come into Sydney for the first time, you don't want these young people going into, or any age people, going into these social settings without information. You don't want someone going into a new, possibly terrifying, possibly exciting setting, but without already having an understanding of how to use drugs safely if they choose to, or how to say no to using drugs if they choose to. So it's really important to ensure that we provide harm reduction materials for LGBTI people so they have knowledge before they're put in a situation where they need to make a decision. Now, remember how we talked earlier about lesbian and bisexual women starting to use drugs at a younger age? So think about the importance of these young women getting this information before they're put in a situation where they need to make that choice. Or gay and bisexual men who may have come out later in life and may not have engaged with the gay community or harm reduction material previously. So the importance of continuing to provide harm reduction and education for gay or bisexual men, regardless of how old they are, where they're sitting on the spectrum, so that people are making as safer decisions as they can and are as educated as they can be in that situation. Something that we also know from research is that LGBTI people are far more likely to be polydrug users. So this means that they use more than one type of drug, quite often more than one type of drug in one session or at one time. So an example might be that people would take ecstasy when they go out, but they might also take amphetamines to have enough energy to keep dancing all night. And then they might take a depressant drug to come down and go to sleep after they've been out. So it's really important to make sure that LGBTI people have access to information about the whole range of drugs. As a service provider, it's also really important for you to remember if somebody's presenting to your service for treatment for a particular type of drug, if they're a member of the LGBTI community, they're more likely to be a polydrug user. They're more likely to be using drugs other than just that one that they've presented for help with. So it's really important to talk to the people that are coming into your services about the extent of their drug use. So sitting down and talking to people in a comfortable and non-judgmental manner and finding out exactly how many different types of drugs they're using. As a service provider, it's so important for you to know exactly what's going on with your clients in this sense. If you're going to support somebody to reduce their use of a drug, or if their aim is to go for abstinence, you need to know if they're going to be using other drugs in this time. You need to know if you are going to be providing them with a treatment option that will contradict or will be affected by other drugs that they may be taking. You need to have an understanding of these things. For example, if you had an LGBTI person that came seeking pharmacotherapy support, if somebody wanted to stop using opiates, it would be important for you to know if they were using methamphetamine, as that would have a direct reaction with that pharmacotherapy. It would be really important for you to know if they were using benzos. So that would be an overdose risk with pharmacotherapy. So there's many reasons why it's really important to understand the spectrum of people's usage. LGBTI people are also far more likely to have comorbid drug and alcohol and mental health issues. Sorry. I mentioned earlier on that lesbian and bisexual women have the highest rates of depression and anxiety. What we see is quite often LGBTI people might be using drugs or alcohol to self-medicate mental health issues or to self-medicate physical or psychological discomfort. So as a service provider, again, it's really important to understand why the consumer is using drugs or alcohol. It's going to help you provide a much clearer treatment plan for people. It's going to give you a much better understanding of where their use is coming from, why they're using, and that gives you a much better option to support people to get to the end goal, whether that is to reduce the number of drugs they're using, whether that's to achieve abstinence, whether that's their goal might be to handle stressful situations without using drugs or alcohol. So again, it's really important to ensure that your intake process involves questioning and understanding your clients, that you provide, if you're providing harm reduction information about drugs and alcohol, that you're also providing information where people can access about mental health issues, that you're promoting services like QLife or other support services. So if people do need psychological or emotional support while they're going through drug treatment or they're thinking about changing their drug using behaviours, that's really important. So some of the underlying causes of drug and alcohol use within LGBTI communities. The majority of the majority of LGBTI people, young people included, have faced homophobia, they've faced stigma. They also suffer what's called minority stress. So being within a minority, being different to the broader population. These things can cause feelings. They can be externally put onto people. You can face homophobia in the street every day, or it could be internalized homophobia. It could be how you feel about yourself. Both anecdotally and through some of the studies, the SWASH study and the Sydney Gay Periodic Survey, we see that homophobia and stigma and minority stress are named by LGBTI people as some of the main reasons why they use drugs and alcohol. Isolation is another really big cause for drug and alcohol use. Many LGBTI people are separated from their family of origin. They may have great supportive friends and community and chosen family, but often people can feel alone and isolated, and this can lead to drug and alcohol use as well. It can also lead to the feelings we talk about drug and alcohol use being quite prevalent in the social situations for LGBTI people. So people who are feeling isolated and unsupported might be more likely to go into situations like events and venues and bars, and might be more likely to use drugs and alcohol to fit into these social situations. We also talked briefly about the normalisation of substance use in social settings. So this is a behaviour that people are seeing reinforced. Again, this ties back into the importance of providing harm reduction materials for people before they get into these situations. So they're going into these social situations, they're going into these areas where drug or alcohol use might be normalised, so they have the information before they get there. I know I keep saying that over and over again, but in my time working in drug and alcohol, it's what I've seen as one of the most effective tools for supporting LGBTI people, is giving them accurate, up-to-date and unbiased information. Alcohol is really a emotive topic. It's really, really easy when you're working in drug and alcohol to put your ideas or moral interpretation onto things. It's really easy to want to say, I think this is doing you harm. But this isn't a healthy way to communicate with people. It's not an effective way to communicate with people. It's so important as workers that we can provide appropriate, easy to understand, succinct health information for people, harm reduction information for people. So if people do choose to use drugs or alcohol, they can do it in the safest manner possible. Increased sexual pleasure is another reason that LGBTI people use drugs and alcohol. There is, you may have heard the term chemsex. Recently, there's been a lot of talk about chemsex. There's been a few documentaries and things come out recently. So there is a higher number of gay and bisexual men use drugs or alcohol in sexual settings than the broader population. Primarily the drugs that are used in sexual settings are amphetamines, ecstasy, amyl, and Viagra. So as a service provider, it's really important to think about how these drugs could be interacting with each other and providing information for people talking about these drug interactions and how people can look after their safety in these situations. And again, as we mentioned earlier, if people are using drugs or alcohol in sexual settings, they might have lowered inhibitions. So it's really, really important that we provide health and harm reduction information about safe sex, safer sexual practices, and safer drug and alcohol practices together. The other thing that we probably don't talk about enough actually, is that LGBTI people may use drugs simply for pleasure. We're talking about people who may suffer stigmatization, who may have faced bullying, who may feel isolated. So they're looking for an escape. They may be looking for a pleasurable, happy experience. And this is what we talked about earlier, that not everybody's drug use is problematic, and that not everybody may realise, I'm trying to find the right way to say this, drug use means different things for different people. So for some people, they may be completely happy with the level of their drug use. So what we can best do for these people is provide safety information to be there as a service provider if they do need to come back at a later time. So not to isolate people for feeling that it's okay or pleasurable to use drugs. We don't want to shame people. We don't want to stigmatize people. We just want people to know that if they do need support at any point, if they do need information at any point, that you're an appropriate service. So you have LGBTI appropriate materials. You have an understanding of the issues faced by LGBTI. Something that does happen in the LGBTI community, and it probably does come from the fact that we do have higher rates of drug use in our community, is that we do have an amazing community of self-care. A culture of care is a term that we used to use to talk about it. LGBTI people are much more likely to support each other around their drug and alcohol use. And it can be really, there's a spectrum of community support. So that can be from organised and resourced programs like the ACON Rover program. So the ACON Rover program is a group of volunteers. It's a great program I had the pleasure of working on for many years. It's a great program of volunteers who go to LGBTI events where people might be taking drugs or alcohol, and they keep an eye on people, and if they think that people are getting into trouble, they go and they support them. If it looks like people need water, they take them bottled water. If it looks like they need medical assistance, they get them to the medical tent. So it's having people walking around in a venue, keeping an eye on people. So it's the community, it's peer-to-peer support, LGBTI people supporting each other, supporting their community. I mentioned that drugs and alcohol can be used in all social settings for LGBTI people. We've heard great anecdotal stories of LGBTI people who have been at parties where people have been using drugs, and things that they do to protect each other and to protect themselves in these kind of settings is recording what drugs people have taken, how many they've taken, and what time. And people do this as a community self-driven harm reduction project. This is ensuring that if something does go wrong and you have to call an ambulance, you know what drugs your friends have taken. You're able to tell the person that comes to the door, this is what's happened, this was how long ago, this is what they had. So if somebody does need assistance or support, this makes it so much easier. LGBTI people are great at looking out for each other. It's really good, and it's really important to encourage that culture of care, to encourage friends to let each other know if they're out and they've taken drugs, to encourage people to check in on each other. These self-implemented harm reduction strategies are great. They actually work. It's amazing being in a venue or being in an event and seeing people looking after each other in these ways. It does happen in the broader community. There's a Save a Mate program that happens in broader at festivals and things like that. It's the same kind of thing. It's community care. It's sharing information and education with each other. It's really important. Something that's really important to remember is that LGBTI people are more likely to take on and understand, pay attention to information if it's come from within their community. So as much information and knowledge that you can provide to an LGBTI person, you may be giving it to one person, but it's going to get handed on. It's going to be shared within the community. So as much information as you can get out there is great. To ensure that you provide effective AOD treatment for LGBTI people, you need to remember that LGBTI people are more likely to seek treatment. Lesbian and bisexual women are 3 times more likely to seek treatment for drug or alcohol use than the broader population, and gay and bisexual men are twice as likely to seek treatment and support than the broader population. So it really is important to ensure that your programs talk to LGBTI people, that you have images and messaging that rings true to LGBTI people, that you have campaigns and posters and resources that picture LGBTI people. It's really easy to make your service a safe and welcoming space. The National LGBTI Health Alliance has a lot of information on how you can make your practice inclusive, how you can be more appropriate for LGBTI people. The way that you can improve your service delivery and some of the ways you can be more inclusive for LGBTI people is to make sure you have age-appropriate targeted messaging. Remember, we talked about lesbian and bisexual women's initiation into drug use can be much younger. So you have messages that are obviously worded and targeted to young people, that has imagery that is appealing to young lesbian or bisexual women, so that they'll pick up the resource, so that they'll have a look and read the information, and they then have the knowledge for when they're put in a situation where they may need to make a choice if they're going to use a drug or alcohol. Make your service as inclusive as possible. That can be anything from having a rainbow sticker on your window, ensuring that all of your service staff treat LGBTI people respectfully and appropriately, or have a read up of the inclusive language guide so you know the kind of language to use when you're talking to an LGBTI person who's in your service. Make sure that your intake forms are inclusive. Think about the gender options on your forms. Think about the options for talking about partners on your forms. Again, these are all things that the National LGBTI Health Alliance can help you with. It's really important to respect your client's wishes in terms of their use. As I said, not everybody's goal is abstinence. So, if you have a client coming into your service seeking any help or support on their drug and alcohol journey, it's a great thing. So, not pushing people, it's a process, and we're not all at the same place. So any support or education that you can offer somebody is great without pushing people beyond where they're comfortable to go yet. Listen to your client and don't make assumptions. It's so easy to say this, but it's just taking a moment to step back and listen to them. Let them tell you about their drug use. Let them tell you about what they're trying to achieve, what's important to them in their lives, and what they think is achievable and the support that they need. And having a good knowledge of other services. It's really important to know which other services are LGBTI appropriate. So if you are referring somebody on to, whether it's a rehab, whether it's a doctor, a social group, that you're making a safe and appropriate referral. People are going to be far more likely to follow harm reduction advice if they feel like it's appropriate for them, if it's safe for them, if it's targeted, and if the service provider understands them. So that's about it, I think, for me today. I know that was very much a kind of quick snapshot. As I said, if you're interested in more data or evidence-based materials, we will pop a list of these surveys and research materials up on the website for you. If you came in halfway through this or you didn't get to see the whole thing, the recording will be available on the website this afternoon. You'll get an email to let you know when the recording and the materials are available. And if you have any questions, also please feel free to email us through to us, and we'll make sure that we get a response to you as soon as possible. Did anybody have anything that they wanted to ask now? No? Okay, well, thank you. Thanks so much. Thank you for tuning in. Thank you for giving up your lunchtime. I hope this was useful, and we'll hope to see you at the next webinar. Thank you. And that was your cameo.
And maybe.